I wanted to talk to you just about the evolution of endoscopic sinus surgery, certainly over my training and my consultant career, and really sort of taking you on a little bit of a journey as to how sinus surgery evolved. So early sinus surgery, okay, so when I was an early trainee, we were still doing inferior meatal antrostomies, and really perhaps because we didn't understand so much about how the sinuses worked and how the sinuses drained, and assuming that it was gravity that contributed to the drainage process. I mean, there are still situations perhaps where large cavity surgery happens to facilitate gravitational drainage. So I'm thinking particularly of cystic fibrosis type cases or ciliary dysfunctions, but really in current practice, I think there is very little role, if any, for an inferior meatal antrostomy. It just doesn't tie in with the physiology and the way that the sinus works. Again, Coldwell Lux was still happening, and not within ENT or rhinology practice, but certainly out with of our specialty area. Coldwell Lux are still happening under some specialties. But I really have to counsel against any aggressive stripping of sinus mucosa, because you have to remember that all we're doing as surgeons, and sinus surgeons particularly, is facilitating nature and helping mucociliary function to restore itself so that the sinuses work as normally as possible. And I can't advocate stripping sinus mucosa in any but the rarest of situations. And then very early on, prior to the evolution of the endoscope, the Hopkins rod, something that's common practice for us now, using medial approaches, so modified Lynch-Howarth type incisions, seagull type incisions, to perform an external frontoethmoidectomy for pathology within the sinuses, frontal sinus, anterior ethmoid sinuses. So really sinus surgery was limited by the equipment and the instruments. So when I started, polypectomies were still happening with headlights. The famous Draff, Wolfgang Draff, used a microscope. So, you know, up until very late, I thought that his was endoscopic surgery. But, if you could just put your microphone on mute, please, Sarah. Thank you. But he was using a microscope to do his Draff type procedures. So, and in parts of Europe, the microscope is still used by ENT surgeons to do sinus surgery. Again, when I started out, the instruments were very chunky, very big, caused mucosal trauma as you inserted them in and out of the sinuses. And anatomical knowledge, because we couldn't really see into the sinuses at a close range, anatomical knowledge was quite limited. So going back to the 1980s, and that's not that long ago, okay, so for most of you viewing this, that will be ancient times, and certainly my children, they call those the olden days. But this really isn't sort of that long ago when we look at historical sinus surgery. And the term functional sinus surgery, endoscopic sinus surgery, or FESS, came about when Stamberger produced what is still a wonderful textbook with fantastic illustrations and focused treatments on an area of the sinuses called the osteomeatal complex, which he termed the functional endpoint of the anterior sinuses, the anterior sinuses being the frontal sinus, the anterior ethmoid sinus, and the maxillary sinus. And so by clearing disease in that area, you could positively, hopefully, influence the function of those three sinuses. And Sam's already alluded to Meseklinger, who really was one of the forefathers of the endoscopic approach. And this is the area that Stamberger focused on, okay, called the osteomeatal unit or the osteomeatal complex. Now, it's not just one area, and often trainees think it's just lateral to the uncinate process, which is called the infundibulum, of the maxillary sinus, but it's the lateral aspect of the middle turbinate, the anterior ethmoid, the uncinate process, the infundibulum. So all of those areas constitute the osteomeatal complex, and so you can see how they influence the function of those three sinuses. So any disease in that area could potentially adversely affect the maxillary sinus, the anterior ethmoid sinus, and the frontal sinus function. And then another thing that's really helped is better imaging. Okay, so high resolution imaging. So you can have varying thicknesses of scans. So all of your scans are taken in an axial format, and then very intelligent software reformats those images into coronal and sagittal views. Now, this is a two-dimensional image. So before embarking on a sinus operation, you should have a look at the three planes. So triplanar imaging. Coronals, because that's how my brain works, I can plan surgery. Axials and sagittals, because your brain then re-assimilates that information into a three-dimensional model. And it's very helpful then to be able to form a picture of what you're going to do intraoperatively. So I have CT scans that are 0.625 millimeter slice thicknesses, because I'm looking for very fine, delicate anatomical changes on the orbits, on the skull base, but they go anywhere from 1.5 to 3 millimeters. So if you're trying to find, for example, a CSF leak on the roof of the ethmoid, a 3 millimeter scan won't be sufficient. So your CT department, radiology department should be going for finer cuts. And again, San's mentioned this already, but the things I'm looking for are the depth of the olfactory fossa. So what is the height of the lateral lamella of the cribriform plate? My brain's focusing on what the ethmoid roof is doing, so the fovea ethmoidalis. And you can see even something that looks relatively symmetric at first glance, when you draw lines, how asymmetric the sloping of those two skull bases is. And I'm also looking at the continuity of the medial orbital wall, so the lamina papyracea, to ensure that particularly in a revision case or a patient that's had a traumatic blow to the orbit, that the lamina papyracea is intact and that I'm not going to get into trouble with either orbital fat or the medial rectus muscle sitting within the ethmoid cavity that could potentially cause complications and trouble during the surgery. Further back inside the sinuses, okay, so the anterior view was the last few slides that I showed you. Posteriorly, we also have a much better idea of anatomy and anatomical knowledge. And so this, I find, another very useful slide. I'm not just looking at the sphenoid sinuses and the fact that the right sphenoid sinus is larger than the left, but I'm also looking at the optic nerves that sit in that superolateral position within the sphenoid sinus. I'm looking at the foramen rotundum on both sides, so my V2 division of the trigeminal nerve, the maxillary nerve, and I'm also looking at the Vidian canals and the Vidian nerves. And you see how all of that anatomy presents itself because you know what you're then looking for. And another couple of structures that are very important when you're working in this area are your internal carotid arteries. Okay, so you can see how evolution of the technology and the instruments, but also CT scanning has gone hand in hand in enhancing our approach to endoscopic sinus surgery. So that when you look at a slide like this, what I try to say to my trainees is it's easy to say, well, there's maxillary sinus inflammation or there's ethmoid sinus inflammation. But I want you to get into the habit of looking beyond the disease process so that you're focusing on the lamina papyracea. You're focusing on the broadness of the olfactory fossa, the height of the lateral lamella of the cribriform plate. San mentioned Kennedy's nipple, so the anterior ethmoidal arteries poking out from the superior and medial aspects of the orbit between the superior oblique muscle and the medial rectus muscle and passing along the skull base. I'm also looking at the lamina papyracea. I'm looking at the position of the infraorbital nerves on both sides. So you see beyond the obvious being the inflammatory disease within the sinuses, and your brain starts to then look at what the important anatomy is before you embark on a sinus case. Very important that you get into that habit of not just looking at the obvious, but also looking for things that are potentially going to get you into trouble during surgery. So what has the evolution been? Well, I mentioned 1980s, so with Messerklinger and Stamberger, really sort of the fathers of endoscopic sinus surgery, and then some really tremendous development through fantastic teachers and surgeons through the 90s and early 2000s. So I've mentioned and alluded to Wolfgang Graf already, but David Kennedy in the States, and the fellowship that I did in Canada was with a fellow of David Kennedy. And really at that time, you fell into sort of two camps of your approach to sinus work and sinus dissection. And then PJ Wormald's been alluded to already in Sand's talk. But these guys were just giants within our endoscopic discipline, and really took sinus surgery to the next level, and making all sorts of endoscopic, minimally invasive approaches possible through the nostrils. So really I want to sort of get into this discussion now about FESS and ES. Okay, so I would prefer it to be called endoscopic sinus surgery, because I hope to be able to show you through the presentation that we're not just doing that endpoint functional sinus surgery, but that there are vastly more extended applications to sinus surgery. Okay, and the basic principles of that are that we're correcting obstruction to sinus drainage, but also making large enough cavities or openings into those sinuses to allow better access for topical treatments. So the surgery is one aspect of the treatment, but your pre and post-operative medical treatment is a significant proportion. And again, I'll go back to what is a successful outcome. A successful outcome is not having to do the operation again. Now, that very much depends on what phenotype the patient is in terms of their inflammatory disease. But if you don't do a good operation and you don't then manage effectively with medication, either pre-operatively or post-operatively, you'll cause recalcitrance and your revision rate for surgery goes up. So I deem that as a failure, but also being contributed to by the phenotype of the disease of the patient. And then really through the 2000s and the 2010s, we've had evolution again, and a rapid climb over the past 12 to 15 years through individuals like Aldo Stam and Carl Snyderman, of really vastly more expanded applications of endoscopic sinus surgery. So it's not just polyp or inflammatory disease, and not just functional surgery, but really for access to the ventral skull base, the central skull base, to be able to deal with pathologies on the other side of the skull base. And this really excites me, because I like working with people. I like to work outside of my bubble, my area. I enjoy working with neurosurgeons and orbital surgeons, and this gives me an opportunity to do that. So this is the sort of view from a suprasellar endoscopic approach after a tumour called a benign tumour called a craniopharyngioma has been removed. Okay, so this is an expanded application of endoscopic sinus surgery. So to get to this point, the patient had a large bilateral sphenoidotomy, a posterior septectomy, the rostrum and the middle third of clivus have been drilled to create space. The sella, so that's the pituitary gland at the bottom of your screen, has been exposed to create space then to go up into that suprasellar area, so the planum and the tuberculum celli, to give you a view of the stalk of the pituitary sitting below, the optic chiasm sitting above. Okay, so it really has given us an opportunity as ENT surgeons to get involved with this sort of surgery. So there's the chiasm above, third ventricles, choroid plexus sitting superiorly, and then as I rotate the camera downwards, you can see the basilar artery, the posterior cerebral arteries, just an absolutely privileged and fantastic view of the brainstem. Okay, so this is what I hope to sort of take you through in terms of a journey from just endoscopic sinus surgery for polyps and inflammatory disease to the more advanced types of surgery. Okay, so what's important as a trainee? Okay, so training, okay, and that's why you're signing in and registering to this sort of session this morning. We've all stressed the importance of knowing your anatomy, and we've made suggestions as to how you might do that. So reading books and YouTube videos, watching the experts, getting yourselves on good courses. We have some fantastic courses across the UK. When I came through my training, there weren't so many courses across the UK. We had to go abroad. I don't think there's any courses, or hardly any now, that we need to go abroad for, and whether that's rhinoplasty or sinus surgery or temporal bone surgery, advanced courses, all of those courses are available in the UK. Learning how to position instruments inside the nose. Okay, so another favourite saying of mine is to remember what you're leaving behind. Okay, so trainees, as they first start out doing sinus surgery and polypectomy surgery, get a little bit fixated with removing polyps and not really thinking about what they're doing to the mucosa of the septum, the lateral wall, the inferior turbinate, the middle turbinate. Middle turbinate's flapping around in the wind, but as long as you get the polyp, that's the most important thing. Whereas I like to change your mindset a little bit to get you to think more about what you're leaving behind in the nose, which is the mucosa, and it's your friend. So being much more careful with your suction instruments and your instruments as you put them in and out of the nose. I think hand-eye coordination, we talked about that already, because you're operating into the nose but looking on a screen. Okay, so again, that's a skill that doesn't come naturally to everyone, and you have to learn it. It can be learned. I don't think you're born innately being able to do microscopic surgery or endoscopic surgery, but you have to work hard to achieve that level of hand-eye coordination. And there's no point going to courses or training yourselves if you're not being exposed to cases. So I think making sure that you attach yourselves to a good mentor, someone who's very busy, who's doing lots of cases. And I have no problem with exposing my trainees, either through courses or through the cases that we do, to exposing them to advanced techniques, frontal sinus techniques, skull-based techniques early on in their training, because I like to set their horizons, okay? So if you're only ever seeing things to not a high level, you don't know what's out there. So I think it's very important that you're exposed to these sorts of cases early on so that you set your horizons and you know what you're aspiring to achieve. Training happens in small building blocks, and we've already talked about the gold standard of human cadaveric tissue, but there are other ways. So the CTs, the ST3s, that you can develop your hand-eye coordination and dexterity skills. You might use a box trainer, which is called a low fidelity simulator. We also have Voxelman and other high fidelity haptic feedback computer-based simulators. Okay, so they are another way of developing your anatomical knowledge and your hand-eye coordination. Stepping up into, say, a sheep model, which has very, very realistic paranasal sinuses. Okay, so thankfully I've never had to dissect a sheep's sinuses, but I'm told that they are very realistic. And then, of course, going to courses to train yourselves on human cadaveric tissues. The advantage is that they don't bleed, but the tissues are wonderful and allow you to adapt and then transfer your skills very quickly onto a human patient in the operating theatre. So they are easily transferable skills. And also over the past 5 years or so, some of you may have been exposed to different types of simulators or simulation models. So this is quite nice, actually. It's a 3D printed silastic type of model. It has good bony replication, and I think it's ideal for when you're learning how to use powered instrumentation, so a micro debrider or a drill. The print on the right connects into the cassette on the left. You can connect it up to image guidance and navigation, and it's a very nice way again of practicing surgical skills and techniques with new instruments before you transfer those skills onto a real live patient. So what are those building blocks? To start off with, endoscopy. Okay, so as CTs, core trainees interested in a career in ENT surgery, you should use your theatre time opportunity with your consultant trainers or registrar trainers to, at the end of the case, ask to hold the endoscope or to look down the microscope if you're doing an ear case. You should take the opportunity in clinic to practice your endoscopy skills. What do I mean by that? Is not hurting the patient, not causing them discomfort, making sure that you're positioning the head in the right position, that you can get the endoscope in and out without causing any great degree of trauma. The next step is polypectomy. Okay, I don't use anything other than powered instrumentation to do my polypectomies. So again, positioning the endoscope, positioning your micro debrider, taking biopsies, they're very important. Then performing a very good and clean uncinectomy and a middle meatal antrostomy. My trainees spend a lot of time doing this first step, because if you do a proper uncinectomy, antrostomy and an anterior ethmoidectomy, you'll treat upwards of 70% of patients who have frontal sinus symptoms, okay? And if you do your uncinectomy badly, your anterior ethmoidectomy badly, you will cause problems in 3 sinuses: the frontal sinus, the anterior ethmoid, and the maxillary sinus. So my trainees spend a lot of time practicing those 3 skills, making sure that they're very proficient by the end of their placement with me. Slightly more advanced techniques, so the posterior ethmoidectomy, the sphenoidotomy, okay, so that happens in the latter parts of training, because the dangers in those areas increase, okay? So your anatomical knowledge should be much, much greater. In the posterior ethmoid, you could come across the optic nerve at the orbital apex. In the sphenoid sinus, I've shown you already that you can come across in the posterolateral aspect, the internal carotid artery and the sphenoid, the optic nerve. So you should know how to get into those 2 sinuses very clearly and without potentially causing any complications. Frontal sinus procedures are complicated. Now, I don't want to say that trainees aren't exposed to these. I think you should be exposed to them, because I think there's that horizon setting aspect of being exposed to frontal sinus procedures. But the frontal sinus is one of those, or is the sinus that if you don't do it properly, you're likely to cause more problems, okay? So rather than fiddling about in the frontal recess or not quite knowing what you're doing with the agonasi or the cap of a well-pneumatized bulla in the anterior ethmoid, it's probably better to leave the frontal sinus. And the way that you improve those skills is by doing a high-level, high-class fellowship that gives you the skills to deal with frontal sinus anatomy and pathologies. And then the final aspect, putting all of those little pieces together, is the extended applications. So what do I mean by a proper uncinectomy? Okay, so the uncinectomy you can think of in 2 parts. This is a left nasal passage, so you can see the middle turbinate ascending process of the maxilla just in front of the 45-degree through cutter. And that was the vertical part of the uncinect process, so one part, and this is the horizontal part. And this is the part often that's missed, not just by trainees, but by others as well. And then just using the micro debrider very gently, okay, not going at it crazy, not going at it at very high speed, but just to clean up those mucosal edges. And then you can see just on the right of your screen there, a very nice natural opening, about 5 millimeters into a maxillary sinus. So leaving that outflow drainage pathway very clean, very clear. One of the trainees asked about the anterior ethmoidal arteries earlier in one of the earlier presentations. So this is the right nasal passage. Okay, so there's been an anterior ethmoidectomy. That's the second lamella that San showed you. That's the third lamella, the basal lamella. So the anterior ethmoidal artery coming out of the orbit, Kennedy's nipple, always sits between the second and third surgical lamellae. Okay, that's the posterior ethmoidal artery that usually sits in the skull base, always sits in the posterior ethmoid. So you have to have resected the basal lamella to get into the posterior ethmoid to see your posterior ethmoidal artery. Okay, so I hope that's a little bit clearer based on that slide. And why do you need to know your anatomical knowledge? Because when you get into a real live case on the left side, when there's blood, so you're in the sphenoid sinus there, okay? Middle turbinate's on the left of the screen. That's the posterior ethmoid, now the anterior ethmoid, and there it is. That's your anterior ethmoidal artery. So if you're not careful, if you run your suction or a curette or a through cutter or your microdebrider in that area, you'll cause an injury. So that's why it's important that you're aware of anatomy before you do a case. Okay, and very thin lamina papyracea on this particular patient. So with orbital fat just being blotted by pressing on the eye. And then again now, building up your surgical skills. So this is a patient who has Graves' disease, so thyroid orbitopathy, so an increased volume in the fixed box, the fixed compartments of the orbit. So there's proptosis and lid lag, and you're seeing more sclera than you should. So how can you treat that? Well, you can start to work in a different plane now, the coronal plane, to decompress the orbit. So the lamina papyracea has been removed there, exposing the periorbiter. And for this particular case, because there was an indication, you can see if you carry that dissection on further back, then the optic sheath sits at the orbital apex. But you can also see that if you're not sure where you are, if you're using powered instrumentation in the posterior ethmoid, you could very easily cause an injury and blindness and a severe complication of sinus surgery. So anatomical knowledge is a priority. Frontal sinus surgical procedures have evolved quite dramatically over the past 20 to 25 years. Okay, so obliteration was rife when I was coming through my training. Osteoplastic flaps, because we didn't have the instrumentation and the endoscopic knowledge and surgical skills. But over the last few years, I think you've all become aware of techniques like balloon sinuplasty. We talk about the draft procedures, so the draft 1, the draft 2, the draft 3. For difficult to reach pathology, tumours, papillomas, cholesterol granulomas sitting laterally within the frontal sinus, I might still choose to do an osteoplastic flap. So this, even though this is an endoscopic talk, I think there are indications still for external approaches. I don't obliterate sinuses. I'm not going to go into the reasons for it, but I don't think it's a good treatment for a sinus, for a frontal sinus. If you have a dysfunctional sinus, I would prefer to cranialise it, and that would be a joint procedure with my neurosurgical colleague. A Rhinology's procedure is quite specific, so osteomyelitis of the anterior table of the frontal sinus, and that's a drilling down procedure to get rid of all of that diseased and inflamed and dead bone. So a balloon sinuplasty, okay. So within my practice, just because of the spectrum of patients that I see, it's not a common procedure, but I still do it perhaps between 15 and 25 times a year. Airline staff, for example, or divers. So patients who work at depth, they may have maxillary sinus barotrauma or frontal sinus barotrauma. But here, a balloon's inserted following that drainage pathway. So Uncinectomy process, you can see just to the left there. So I'm behind the agonasi, following the bulla-up, behind the beak that San demonstrated to you in his anatomy talk. And you go through this process of serial dilatation with the balloon. So that was one dilatation, just opening up a pathway. And you can see there that the balloon just slips very nicely then into the frontal sinus. And then there's a second dilatation then just to open up that drainage pathway. So again, you know, for isolated frontal sinus disease, there was a little bit of polyposis on that free posterior margin of the Uncinectomy process, which we could manage with steroids. But you could see how, without being very aggressive, you could create a drainage channel then into that frontal sinus. So my endoscopic view as I come in now will show you then just that opening as we go up into the frontal sinus there. So that gives an opportunity to aerate, but also then to be able to get medication up into the frontal sinus. I hope you recognise this as a post-draft 3, and again, for the astute of you, you won't see much disease there. This wasn't an inflammatory case, this was a skull base access case on a patient of mine for an olfactory groove meningioma, and they're actually very nice cases to do from a sinus perspective because there is no or very little sinus disease, but the patient had a facial bones x-ray for some other reason, and I took the opportunity to take this slide. But you can see that's a classical post-draft 3 type appearance. And then building blocks. So when you're putting all of those building blocks together, okay, so this is now familiarising yourself with the use of a drill inside the nose. So there's the orbit on the left, the orbit on the opposite side is the right. Both middle turbinates have gone. There's been a draft 3, a complete ethmoidectomy on both sides, a septectomy, sphenoidotomies. So really now this is taking it to that next level of exposing the ventral skull base. So putting all of those sinus endoscopic procedures back to back, and using those building blocks then gives you exposure to the skull base to be able to do the more advanced endoscopic techniques. I won't go into too much detail about the skull base resection, but it's just to expose you to both the sagittal and the coronal plane. So there are different modules, but you can see how with an endoscope I can get to any of these areas of the ventral skull base, okay, by removing the ethmoids, by opening up the sphenoid sinus, by doing a modified endoscopic Lothrop procedure. So all pathologies on the other side of the skull base become accessible to me via an endoscopic approach, working with my neurosurgical partner. And then just to say, sort of finishing off really, that there are still indications for external approaches. So although there'll be no doubt from this presentation that I'm a massive fan of the endoscopic approach, but I am still knowledgeable and skilled about external approaches, because there are indications when you will have to do an external approach. So this is a bicoronal incision, and the reason for that is very abnormal frontal sinus pathology. So by the time the patient gets to this stage, because of their underlying disease process where they just produce very abnormal mucus, and there's been a great degree of new bone formation, you know, that frontal sinus really isn't offering them any advantage whatsoever. So via a bicoronal incision, I'd cranialise that frontal sinus with my neurosurgical partner and seal off that communication then between the frontal sinus and the intracranial cavity to give them that sort of post-operative appearance, so asymptomatic after that sort of surgery. Just to finish off then, a few slides just about consent and risks. Okay, so this is, Tim talked to you about his consent process for rhinoplasty surgery. This is my consent process for sinus surgery. Bleeding, infection. I always talk about loss of sense of smell. I can say that none of my patients have permanently lost their sense of smell as a result of my surgery, but they may well, other than the skull base cases, so for example, olfactory neuroblastomas or olfactory groove meningiomas, where I've cut the olfactory bulbs. But during routine sinus surgery, unless I'm doing a draft 3 type of operation, I have little concern about loss of sense of smell. I think it has to be a perfect storm, like a plane crash. So surgery around that area, a post-operative infection, a number of things coming together to cause a loss of sense of smell. But I think it's always worthwhile you documenting in the case notes or your letter to the GP that the patient had a normal sense of smell or a fair sense of smell, if you're not going to measure it with sniffing sticks or any other sort of objective measure of test. Talk about CSF leak, talk about double vision. talk about blindness if you're going into the posterior ethmoid and the sphenoid sinus, and also talk about recurrent disease, because there is a chance that you will have to go back to do a second operation at some point. So my key learning points are, I was asked to talk about FESS, and I apologise. I've talked about ES. Okay, so endoscopic sinus surgery is not functional endoscopic sinus surgery. It has evolved. I think it's very important to know your anatomy. A couple of us have said now the importance of courses and going on courses, and not just the once. I think fellowship training is very valuable. You'll come out of your training as excellent generic omnipotent surgeons, from head and neck to laryngology, from sinus to rhinoplasty to ear surgery and pediatrics. Okay, but I think it's really important that you use a fellowship year, if you're interested, to focus your minds and focus your thoughts and do a large volume of cases. Not just the cases, but it's getting into the thought process of your mentors. Attach yourself to a good mentor, okay, extremely valuable. People that talk sense and do a lot of cases, and aim your bar high, okay. So, you know, I can't stress that last point enough. Okey-doke, that's me.
So Raj, hi, it's Shom here. Just got a couple of questions for you. So Murari's asking, so do you perform balloon sinuplasty procedures in clinic or theatre, or where would you recommend doing them?
Yeah, Murari, both actually. So I'm a big advocate of local anaesthetic sinus procedures. I'm afraid I was put off them as a trainee because we didn't have very good local anaesthetics. We didn't have very good instruments. We had big instruments. We didn't have microdebriders. We didn't really understand sinus anatomy. And I was put off local anaesthetic procedures very early. But all of those things have changed now. And I think we're better at sinus surgery. We just are. So I do local anaesthetic procedures in theatre. So my trainees who work with me are exposed to those early on, and I think there is a case to move those into the office setting, the outpatient setting, and that's something that is happening more in the States, but some of us are starting to do now in the UK. So Mr. Carey, for example, up in Newcastle, and others dotted around the country.
And thanks, Raj. And then Tunde, we might be coming to this in the case discussion. So Russell, what's your opinion of doing frontal balloon sinuplasty in the first instance alongside anterior FESS if you don't have extended frontal sinus surgical experience?
Yeah, I think that's very reasonable, Tunde. People talk about full house FESS, okay, so where you address all of the sinuses, maxillary, ethmoid, sphenoid, frontal. Some of you won't have the skills to be able to do extensive frontal sinus surgery. But I think where I draw the line is that you make a decision about whether it's reasonable or whether you're just tempering the patient's symptoms and that you expect their symptoms to come back, okay? So I've mentioned to you already that one of my measures of failure is a high revision rate for your surgery, okay? So it's okay to use a balloon, but if you think that you're going to have to do the operation again, okay? So I prefer a definitive approach to the surgery, and that's a judgment call when you assess the patients in clinic.
So we'll just take two more questions. So from Darren, moving forward towards the future of medical legally, do you think all S should be used performing some form of navigation system? So do you think all S should be performed?
You know, this, look, Darren, I'm going to answer this with a no, okay? Because I don't think that everyone will have access to navigation systems, okay? Now, I use a navigation system for a lot of my surgery, but I don't use it for all of my surgery. Why? Because I'm very comfortable with anatomy, okay? Where I think you will be criticised is if you have a navigation system in the hospital or in theatre or with a colleague that does navigated surgery, and if you cause a complication but didn't use the navigation system, okay? I also think that navigation systems give surgeons false sense of security. So they make you think that you can carry on with an operation when you're out of your comfort zone, okay?
Thank you. And final one before we move on to the case discussions, because we're running really well to time. So Tunde is asking, have you made any operative changes due to COVID? So I know you've done some skull-based cases, such as drilling, etc.
Yeah, Tunde, great question and very topical. So there was a lot of alarm, rightly so, at the outset of the COVID pandemic. So about 12 to 14 weeks ago, and we were pretty much shut down. I think it's been shown since then that a lot of the literature that came out early on was exaggerated, and that microdebriders, for example, have since been deemed safe. And when I'm using a drill inside the nose, Tunde, I obviously have my full PPE on, FFP3 mask or a respirator, I have my visor or goggles on. I have a suction inside the nose. So there's continuously a suction element where all of those particles of vapor or spray are being sucked up into my suction. So you'll know when you're doing these cases, there isn't this cloud of spray around the nostrils that everyone's just being blinded by, okay? So I think we have to put all of this into context, and there are safe pathways now in place in this COVID era that I think is going to be with us now for a good while.